everybody. Welcome back to our 8th master class, Improving Maternal and Infant Outcomes Through Mental Wellness Initiatives. And this class is delivered by Lauren Jones. Lauren is a wife, mother of 4, and she's a mental health advocate. She's also the co-founder and executive director of MomMe, a peer-led nonprofit supports families facing maternal mental health challenges. MomMe was birthed after Lauren experienced severe postpartum depression, anxiety, OCD, PTSD, and suicidal thoughts during her first pregnancy. She turned her pain into purpose and, along with her sister, established the evidence-based community organization that offers culturally competent care, therapeutic services, and peer support. Lauren's work is rooted in her lived experience, in her compassion, and in her deep commitment to breaking stigma and transforming the system of maternal mental health support. So in this series, and in this class in particular, all of you will explore the vital connection between maternal mental health and infant outcomes, emphasizing early recognition of perinatal mental health challenges and looking at evidence-based strategies for wellness. You will also be equipped with practical tools to address stigma, reduce risk, and improve maternal mental health and newborn birth outcomes. This masterclass empowers healthcare providers, advocates, and leaders to promote emotional well-being as a foundational element of maternal and infant health. So, Lauren, welcome. I'm so glad you're here.
Thank you for having me, and thank you for that lovely introduction.
Yeah, it has really, it was a lovely process that led you to establish MomMe. And over these last few months, getting to know you and learning about your organization has really been inspirational, because maternal mental health and mental health and well-being are important to me. So I'm interested in learning from you, and just want to give you every opportunity to take the floor and teach us.
Well, that's funny you said that it's important to you. 9 times out of 10, when someone asks me what I do, and I actually explain to them, oh, I'm in maternal mental health services. If they know what it is, they say, wow, that is a so needed area of focus. And if they don't, the second I say, oh, I did with postpartum, they're like, aha, my sister, my mother, it's so much relatable. So I am very excited. And maybe excited is not the word I should use, but I always get a little giddy when I get an opportunity to share my experience. Not only my personal experience, but my professional experience, to be the voice of so many mothers, so many families that are dealing with maternal mental illnesses. So as we go through over the next hour or so, this particular masterclass, it is my hope, and if it's okay, we can jump into the learning goals, is we want to identify the link between maternal mental health and maternal and infant outcomes. As an organization, we have found through research, through our own experiences, there is a linkage. And I hope that as I go through the next couple of slides, you would actually be able to piece that link together. The other thing is, we want to recognize early warning signs. We don't want to miss any more opportunities to catch some of these mothers and families earlier, so that we can improve outcomes, not only for infants, but maternal outcomes as well. We're going to explore through evidence-based mental health wellness initiatives. And we're going to also talk about the role that culture plays in this, and what cultural responsive care actually looks like or should look like. And then lastly, we're going to leave you with some actionable strategies, right? Something that you can actively implement as soon as tomorrow, because they're easy. So let's jump right in.
Okay.
The link between maternal wellness and maternal infant health. What is that? So maternal mental health is not a side issue. Let's get that straight right now. It is not a side issue. It is a vital component of maternal care. It should be treated as such. It's imperative to healthy pregnancies, safer births, and ultimately infant development and maternal outcomes. I would ask the question, what is the number one health condition leading to maternal deaths? Most of you would probably say cardiovascular disease, right? We've heard of preeclampsia, some of the others. But actually, in the United States, the number one condition leading to maternal deaths is, you guessed it, maternal mental illnesses.
Oh my goodness.
Yeah.
Do you know that in the last century, so 100 years ago, 1900, the leading cause of death in women was pregnancy and birth. So, certainly we've made progress in the last 125 years. Right? So, you do hope so, but
Yeah.
progress, we haven't reached perfection yet. And everyone has, here's the deal. Everyone hasn't benefited equally from the progress, right?
Agreed. Yeah, absolutely. And we'll talk a little bit more about that inequity
Mm-hmm.
as we go along. We know that Black women are 2 to 3 times more likely to actually experience maternal mortality in birth than our uh, white counterparts or Caucasian counterparts, right? But PNADs, or perinatal mood and anxiety disorders, are also the leading complication in childbirth. So not only is it the leading cause of death, but if that mother should not expire during birth, it also is the leading complication that she has to face. And this is personal for me, y'all. If you don't mind me getting comfortable in this area for a minute, I experienced postpartum or perinatal OCD. And as I go through some of these disorders, you'll see how they kind of bleed and blur lines between disorders. So I had about 4 disorders in one. Everything from OCD, depression and anxiety, to PTSD. And it wasn't until nearly 2 years after giving birth that I actually understood I had a medical condition.
Right.
Yeah.
Isn't it unfortunate the way we have medicalized mental health and separated it from the rest of the body?
Yes, absolutely.
I am a faculty member, at the University of Florida. And Lauren, here's what I always would tell my students. From my chin down belongs to my primary care physician, and I see her at least once a year for screening to make sure that I am healthy. And my mouth belongs to my dentist, who I see twice a year, screening to make sure I'm healthy. And what's here? That belongs to my counselor. And you know what? I see her at least every year, whether I have something going on or not, because I want a mental health tune-up. I don't want to wait till things about an exam day. Because no one's born knowing how to navigate life and navigate relationships. So
True.
all of us have something to learn. There should be no shame in saying, I don't know. I wasn't born knowing that, right? Because none of us is born knowing with this information.
So true. And that goes for the physicians and everything that treat us, right? They go in for a specific practice a lot of times. We shouldn't expect them to know everything, but what we should expect them is to go above and beyond in finding that continuum of care for us and making those partnerships and referral links that we need.
I love that.
Yeah.
Just like if you have a referral list for other physicians and you use that list to make referrals, we want to have, because our patients have more than just medical needs. So if they're coming to see us, are there counselors that we can recommend? What about adult education programs? Where are they in the community? And we should have a list again. Not that we can be everything like you said, but just some general information.
But why do we ignore the brain? It's the second largest organ in our body and the most important organ within our body. It is our central control system.
The motherboard.
It's the mother. I think they describe it in school as the circuit board. Think of it as a computer. There's the central processing. It is the something having my age without. But so back to what postpartum depression, how it affects here in Mississippi. Nearly 21% of women experience it, which is among the nation's highest rate. So I'm going to come back. It's going to link up, I promise y'all, but keep that in mind. 21% of women experience postpartum depressive symptoms here in Mississippi, and it has been known or deemed as the highest rate nationally.
Oh my.
Nearly 80% of these women who experience maternal mental health disorders go undiagnosed or untreated. So there lies another problem for us, right? This next slide, maternal mental health disorders. I typically actually don't talk about the onset, but I think it's important that we do understand that perinatal mood disorders, mood and anxiety disorders are no longer considered postpartum only.
Right.
Although that is the largest time frame of onset of symptoms, 40% or so happened after giving birth. There's another whopping 33% that actually begins to show symptoms during pregnancy.
Wow.
True story. I was on psychotropic meds for anxiety. High stressful job before I got into the lovely world of nonprofit and advocacy work.
There's no stress there.
Oh, none. But had a clean pregnancy with my husband. Went in, told my OB that I was on these meds. My first pregnancy, I experienced postpartum depression to the point of suicidal ideations. It got really, really dark for me. Even with knowing the knowledge, planning a pregnancy, being proactive, my physician, cold turkey, told me to get off of psychotropic meds.
Yeah, I could get at home and just do yourself.
And I'll maybe reference another case a little bit further along when we get to talk about psychosis, a national case that I'm pretty sure everyone has heard of. But okay, so what were we talking about? She said maternal mental illnesses, she's called it postpartum, and she's called it perinatal mood and anxiety disorders. Well, they are one and the same. The most commonly used term to date has been deemed to be perinatal mood and anxiety disorders. And this is an umbrella term that is used to encompass not only the maternal period, the birth period, but also the postpartum period. I share that information because it's important as you are explaining to your patients, to your clients, to your mothers, to your families, in that culturally competent care, it's important to know how a mother, if she's aware of perinatal mood and anxiety disorders, she may not know it by that name.
Right.
Again,
To get a technical long game.
right, it is. So a lot of times, especially in the Black community, we still know it as postpartum. When you say postpartum, the aha light bulb comes on. So what is postpartum depression? We'll start there. So first of all, it's the most common of all of them. It affects nearly 14% of childbearing individuals. I'm going to stick a pin in it and also say this is not only effective to mothers only, it also affects fathers. If a mother experiences a perinatal mood disorders, the spouse is also, or partner, is also 50% more likely to also experience a perinatal mood and anxiety disorder.
So how did your husband weather your pregnancies? Seem to impact him?
No, he experienced it. Yeah, my husband actually experienced postpartum depression. He was great with the first one, but by the time we had our second child, who is now 5, he became, for him, it looked different. It was distance. It was a quietness about him, and I jokingly tell people now, anything that he could do outside of the home, he was trying to do. Yeah, and we talk about it, we laugh about it now, but these are real issues that can actually cause a divide in families. We went through a really rough patch, so it's just as important to arm the significant other with the same knowledge that you arm the mother with, because again, it affects them too. It actually impacts the entire family unit.
Right. I can see that.
Yeah, absolutely. No one's immune. So symptoms for postpartum depression, or PPD, as you might hear it called, are changes in appetite, sleep disturbances, energy levels, lower energy levels, motivation and concentration, kind of all over the place, or lower levels of concentration. Negative thinking patterns. I experienced this one. I think as mothers, we all experience mom guilt. They have actually coined a term for it. But this is guilt beyond typical motherhood standards, right? It's feeling of hopelessness. It's feeling of worklessness.
Okay.
And all of our trainings, they don't talk about this one enough. Irritability, anger, rage.
Those are great big words right there. Yeah. And a lot of times it's almost like a blue pop. Like, for a lot of our moms, they've expressed it as an explosion for them. That it's usually aggressive in nature to the nearest support person. I don't know why. I guess it gets a first area there in the line of fire. There's also disassociation, lack of interest in a baby. This also happened to me. I can probably check off every box, y'all. So you're going to hear me saying me too a lot in this presentation. But yeah, I remember when my daughter was born, I instantly loved her as her mother. Sure.
But I also didn't feel like she belonged to me. That's the best way I can describe it. And thank God for the family that I have that was able to pick up the pieces, because the company photo that I typically use is a candid shot my dad took of me on the couch with my newborn baby. And he was a happy grandpa, but he missed all the signs. It was literally in my face that I was somewhere else. Of course, there's low self-care, right? You don't want to get up, you don't want to move, you don't want to do anything. So what falls to the side? Us. We don't want to comb my hair, take a shower. There's also a decreased level of our libido, our sex drive. Not interested. I'm tired, don't have the energy, may not even be liking my spouse right now.
I may not be there. He's dealing with his own issue. They are not being attended to.
Absolutely.
Oh my.
And then lastly, those intrusive thoughts. Self-harm. I'd be better off, or my children and family would be better off if I'm not here. Yeah. Yeah. A lot. So how we teach this is, instead of necessarily going through the list of the symptoms, listen to what she does say. So what a mother with PPD might say is, I'm so irritable. Why irritable? I don't know. Cry all the time. Yeah, see, that was me. My favorite place to unleash the cry was in the shower. And I tell people, I don't know if it was because I was trying to mask the tears with the water or drown out the sound of me crying. I don't know, but that was my safe place.
You could be sure you're not going to be interrupted, would be my thought. Then it was like total privacy. Yes. You guys don't have to be the strong woman and like mom. You can.
And I tell you what, I flipped it. Now the shower's still my favorite place.
and my only place to get her for my husband and kid. Water bill may be higher. That's my self-care.
There's also the best way, and I probably should have put this one first. I just being known. We hear so many women that are experiencing depression categorize it or use that phrase. They either say it's heaviness that they can't explain or numbness. Some women describe it as, I don't want to leave my home. I just don't feel like doing anything, right? That's that fatigue, low energy. I don't know who I am anymore. Loss of self-identity, right? There's that huge transition. So they're screaming out for help. They may even associate it as feeling ugly, which then makes sense why they have a lower sex drive too, possibly. I can't stop eating. Sometimes this one can go either way. They can overeat or undereat.
Sure.
And then favorite, I just can't explain it. What's wrong? I don't know. I just can't explain it.
Right.
So that is postpartum depression. So as you are seeing your patients, your mothers, your clients, listen to the things that they are telling you. Just take a moment. Even as we go over screeners, it's important to listen for the cues that they do give us.
Right.
Right.
And maybe in conversation, just the things they say informally or the explanation or extra information as you're going through the questionnaire.
Absolutely. We can catch a lot, really, if we're not already on to the next step or the next client. This is true. This is true. So there's also perinatal anxiety disorders. This one, no lie, we saw really a 300% increase of clients reporting this during COVID. It was the number one reported mental health disorder that we saw come through our warm line, direct office, and provider referrals were all around anxiety. Naturally so, we were going through a pandemic. They were, one of the top classes that we were supposed to, pay attention to because mothers were dying during, COVID, unexplainable deaths. So naturally. So what is anxiety disorders in maternal health as we talk about maternal health? Well, worrisome. It's the number one thing, right? Feeling stressed or worried, overwhelmed. Panic attacks. So anxiety disorders are more characterized by physical symptoms. So a person may feel as though they are actively having a panic attack or may be actually having the panic attack. Shortness of breath, rapid pulse, dizziness, chest or stomach pains. And I get this a lot, stomach pains, because I deal with anxiety. And it's true. When you go in for a massage, where's the first place they start? It's usually we're right here. And then they say, oh, you're so stressed. You're tight. So so we think of anxiety as actually physically sitting up in our body. And taking charge of our physical being. There's also the fear of going crazy. Like, it's unexplainable. I just know I'm not myself. I'm here, there, I'm everywhere, so they do categorize it as going crazy. There's also intrusive and scary thoughts and thoughts of harm as well. There's usually a fear around a particular action. And I use this one particular mom that I stare with because she was such, what's the word I want to use for her? Her journey and how she dealt with it was really take charge. So her anxiety stemmed around putting her baby in a car. She was terrified that if she put the baby in the car, she was going to have an accident where she left the baby with the parents. The parents would go against her wishes and take the baby somewhere in the car and have an accident and something. Yes. So it was paralyzing. Yeah. So she came to us. She got with the individual therapist and a peer support, and she also attended support groups. And we gave her resources. And what she did with those resources is she actually became a child safety technician. And for about a year, she actually trained moms in our program We have a car seat program where we give out free car seats, but there's a training that goes with it. So she empowered not only herself in situation, but she took charge of it and helped others. So I just love this story.
That's what I love about your program is that your program chose her to empower her. You could have chosen other women, but knowing that this was something that she struggled with and knowing that if you empowered her to be that person, that it could help her grow through fears and anxieties.
She is doing amazing. Her son just turned 7, I think. So love her. And then there's also sleep disturbances as well, difficulty falling asleep or staying asleep. And it's usually because our mind's going. Our mind's going. So what a mother might say is, I can't slow down. I feel worried all the time. I feel like I'm having a heart attack, or I'm scared to, like hers was, I'm scared to put my baby in a car seat. I can't sleep. I can't shut my brain off. This one is a telltale sign for me. I just don't have an appetite. A lot of times they're already in the next room or down the street doing something else while their brain is still here. So, and then I'm having scary thoughts. The next one I'd like to talk about, but does not get a lot of limelight, is perinatal obsessive compulsive disorder. So I had not really heard of any of this 20 years ago with my firstborn, other than postpartum. But I didn't know anything about it really. I definitely didn't know anything about OCD in pregnancy. Well, this is the one that actually really kind of crippled me in my pregnancy process. And what it is disturbing, repetitive, intrusive thoughts. And they're usually thoughts around either self-harm or harm of yourself or harm to the baby. And for me, it was harm to my baby. So even though I was struggling being a mom, I could not let my daughter go outside of my sight other than with my sister. Had the most loving parents in the world, supportive on every level, but I couldn't even trust them with my daughter because the repetitive thought process. Yeah. So we don't have a lot here because again, it's not a lot of that. We don't talk about obsessive compulsive disorders for some reason, and research is still out on it. But what a mother might say is, I'm having weird dreams. That's usually the first one. Is it comes in a dreamlike form, and then if she ever says, I'm afraid to be alone with my baby, and she's in fear of the thoughts taking over, but the thoughts actually don't align with her values. So what I mean by that is she would it pains her because the thoughts are so intrusive. In her normal state, she knows it's wrong.
Right.
She would never act known or whatever. But these thoughts are there, right? So that's why she says, I'm afraid to be alone with my baby, because she doesn't trust herself anymore. 9% of childbearing individuals typically will experience perinatal post-traumatic stress disorders. Yeah. So people, you can have PTSD around birth. And what that is typically change in mood, arousal, usually all associated around this traumatic event. There with examples. So my firstborn, it was just all peg, y'all. So my firstborn, I was at hospital with my name, but it was a teaching hospital. And you understand that in order for physicians to learn, they actually need to engage in hands-on things, right? But I was a young 21-year-old, knew I was going to be a single mom, parents, North Mississippi. So my prenatal appointments were here, oftentimes alone. And the appointments were, the information that was given, one, was not on the level that I could actually understand. For first of all, being a first time parent, not understanding, and then secondly, just a level of privacy and dignity because it was multiples in the room, and it almost felt like cow, right? Just herding in and just one after the other checking you. So yeah, there's that. Then there's the avoidance of stimuli associated with trauma. So avoidance.
Sure.
Don't me. I never, ever, ever wanted to have another child because of that situation. And then constantly feeling on guard, hyper system. So a lot of women describe it as feeling belittled or incompetent. They may even say I felt raped and my dignity was taken from me. I was treated like nothing, or I felt rushed or coerced into decision making. So doctors know best. And I say that jokingly, right? But that's sometimes the aura or era that you get when you go in is that just do what I tell you. There's not a two-way conversation.
About five here are other speakers in their master classes have stressed the importance of shared decision making. Yeah, so no, because again, it is a partnership, and you're going to have the best outcomes and experience when you communicate. How you communicate honestly and respectfully and hear what the other person values and things.
Absolutely. I like that. Honestly, it communicate honestly. I was in another training and was talking with physicians, OB specifically, and we were actually talking about trauma. And what they viewed trauma as was totally different than what our mamas view trauma in their minds. So if we're training our mamas to put together a buzz plan, right, and we're teaching them advocacy, their rights as a patient, and all of these things, and from a first time mom, I have a placenta abruption. I go in on a checkup. You tell me I have to now be rushed in for a life-saving C-section. That's traumatic possibly for me, right?
It goes very fast. You got to make decisions now, right? Yeah.
And on the other side of that, physicians looked at it like, I did a great deed. I possibly saved you and the baby's life or whatever. So do you see what I'm saying? They didn't view it as trauma. They viewed it as, we caught this just in the nick of time.
So they were listening at, physicians are trained to diagnose and treat.
Yeah.
And they have an evidence base for the decisions they make. And so they follow their plan. And we as patients are living our experience.
Yeah.
And we don't understand evidence base. We don't understand diagnose and treat. We want help me. So it's conflicting models because we're coming at the same problem, just different. Exactly. If like that elephant, and you blindfold somebody and you put them at the front of the elephant and ask them to describe as it and to get to the back, and it's like, oh no, it's big and round. Right?
Yeah, absolutely. Just like that. We're all trying to get to the same product ending results, but we're coming from two different viewpoints. Yeah. So then there's also perinatal bipolar disorder. It is just that. It is just exacerbated in the maternal or pregnancy phase. So it is more reoccurring during this time frame. Symptoms, of course, are manic, hypomanic episodes, unusual shifts in mood, bursts of energy, lack of energy. So we call this one the highs and low disorder. I think that's the way to put it. Yeah, it is on the lesser reported as common disorders, but what a woman might say who's experiencing this is, one minute I feel a burst of energy, I'm bouncing off the walls, and the next I can't get out of bed.
Oh, goodness.
Or I can't seem to ever get anything done. And that's usually because their brain is so then it just shuts down everything. So And lastly, but definitely not least, is the most severe of them all is postpartum psychosis. It is also the rarest of them all. I've made the only 1 to 2 per every 1,000 births or so. But every time I talk about this one, I talk about Andrea Yates. Yeah, she's really like the poster child for this one. How many years ago was that? Really? 2001. 2001 was really the first time that we ever talked about postpartum psychosis and actually got a glimpse into what it was. Now, it's unfortunate that it came from her drowning her 5 children. Yeah, in the bathtub. In the bathtub. Yeah. So, this one is more severe. I can't say that enough. It should not be ignored. But it is described as delusions, hallucinations, paranoia, rapid mood swings. The onset is also usually not too far after birth. We're talking like within 2 weeks. So right after that baby blue period, you can start to see some of these symptoms. It's cognitive impairment. It's usually a fixation around death. Yeah, death. Reckless behavior, and then ultimately infanticide or suicide. So what a mother might feel, and I can't say what a mother might say in this one issue because we've been lucky enough to not actually have a mother come to us actively experiencing psychosis, thank goodness. But in the more severe cases, a lot of these women are either dead or in jail. So we don't have a way to say what they say, right? So what they might feel is fixed false belief, often illogical or bizarre, right? You're just like, what? Like, wait, when she tells you something, what? You might be content around sexual, religious, or violent behavior. Thoughts are a part of a larger delusioning scheme. And they usually plan to act on these thoughts. So hearing voices, receiving messages that tell me to do something. Yeah. So yeah, why is she telling me one by one about all of these disorders, right? Because I told you I was going to link it together. So these disorders directly impact not only baby, but also mother. And we know that what mother feels, baby feels. So it's important that as we're checking baby, which is in mother's belly, and that we don't leave out mother. So some of the impacts of maternal mental illnesses, one, the mother may be poor pre and postnatal care. The reason we say this is because if she's severely depressed, it's hard to get out of bed. And if I get out of bed, I'm going to pick and choose the things that I do. Then sitting in the doctor's office all day long is probably not my first thing, especially if I'm experiencing discomfort, so heaviness. Obstetric complications like preeclampsia, gestational diabetes have also been shown to be at an increased level for the women that are experiencing maternal mental health disorders. They're also more likely to experience these other complications. Increased risk of substance use disorders, self-medication.
Right.
I just want to feel better.
Down the pain.
Nothing the pain. I just want to feel better or not feel at all if I am feeling. Then there's the impaired infant bond. Like I explained in my case, right? I loved my child, but I was mentally and emotionally unavailable.
Right.
This, which then leads to fewer interactions, fewer positive interactions with child. So this one is where I worry about, ACEs, adverse childhood experiences. Thank you. That could lead to harm for a child. Their little bodies and brains are developing in situations where I am mentally or emotionally unavailable. I'm not teaching them good behaviors to mimic. to grow good emotional behaviors, to shed verbally abusive, verbally abusive. I was going to the vinegar, yeah. Breastfeeding challenges. That's what we don't talk about. So it was done in hospitals. You're going to get breastfeeding information on how great it is for baby. But if a mother is severely depressed, it actually can impact her flow. It can. And then, of course, death or suicide by suicide. So how does it flip? Now that we know how it impacts mama, how's it going to impact baby? Sure. Preterm births, low birth weight, stillbirths, longer NICU stays, right? Think about it. The preterm, low birth weight, then they're going to have to stay in the hospital longer to develop excessive crying. This one they definitely don't really talk about. My daughter was severely colicky. And I will tell anybody, if you have never heard a baby cry constantly, it alone will see you into a whole different state. So then back to the ACEs again, right? Behavior, cognitive, emotional delays, all the things that a baby learns, 0 to 5, 0 to 3 especially, and then infanticide ultimately. So it's very important. Again, what goes on in the brain is attached to everything else in our bodies and these outcomes. So it is important for us not to ignore it. Like, I shared this slide with you, the next one. And so just to drive home that point that our mental health is directly impacted, how it directly impacts infant outcomes here is the latest report from Marchadons. They give out nice report cards, state by state. And here you'll see this glaring red F for the state of Mississippi. Here. Yes, we are dead last in the U.S. for the number of preterm births. Our state, dead last, like can't go anymore. I'd also like to bring attention to the Black birthing baby or the Black babies are of greater disparity here. If you will see, they are almost 1.5 times higher rate than other babies, all other babies. So, evidence-based interventions. Not all interventions, as we know, are created equally. So, evidence-based initiatives ensures that care models and wellness programs are effective, scalable, and responsive to the unique needs of the populations that, they serve. Why is it important for early detection? Why? Well, we want to improve maternal outcomes ultimately. That's it. That's the number one reason is to improve outcomes for mothers, babies, and for family units. We want to support infant development. We want to reduce the risk of chronic mental illnesses long term. We want to prevent more severe outcomes like mortality. We can't come back from that. And then we want to encourage support and reduce the stigma, right? That's the easiest way is actually to start by reducing the stigma.
And I think that's the hardest thing to tackle because it's invisible, right? Yeah, it is to the invisible disorder. It's powerful. You can feel it. You can see it, but you can't touch it.
You can't touch it. So it doesn't exist. Yeah, thank you for saying that and acknowledging that. I think that's difficult. Yeah, it is. So the next slide or so, we'll look at these interventions and assessments that are recommended or suggested by ACOG. And we're going to talk about why we want to use these. One, because they're free. Money is always an issue with every organization, and it's always going to be about money. It's easy to administer. That's another one, right? And then it's available in so many languages, like 60 plus languages. So these tools are accessible.
Now, I'm going to have to say, you completely surprised me with your answer. Well, because I figured the number one reason you would want to use it is because it's ACOG. Well, because and it's able, it's valid. You know that you have, you know, medicine and the OB-GYNs behind the screening tool. So it's it's going to make a difference. And then all those other things.
Well, believe it or not, yeah, I agree with you 1,000%. So ACOG's suggestions are, and I'll kind of lump depression and anxiety together. So there is the universal screening, we call it the NBERG or EPDS. We actually use it at our organization. It is 10 questions, very simple, straightforward, no big words, can be self-administered. There's also the PHQ-9, which we found that a lot of physicians and hospitals like to use for screening for depression. ACOG recommends that we do this at that initial visit, somewhere around that 24 to 28 week mark, and then once in postpartum. So 3 touch points. Yeah, I agree with them on
It's
that.
the improvement. And the reason I say that is I had a nursing student, okay, who was researching depression because of her own lived experience. And she was saying part of her thesis was we need to be screening more often.
Agree.
And so agree here now. You're bringing the evidence that agree. Yes, message heard.
Yeah,
Right.
because if you remember on that 3rd or 4th slide or so, when we talked about the onset of these, right? So we can no longer wait to just the postpartum period because we know that 33%, right, start exhibiting symptoms during pregnancy. For anxiety, they recommend the GAD-7, 7 simple questions, also same intervals. Mission appointment, 24 to 28 weeks, postpartum. Bipolar disorder recommends that there is the mood disorder questionnaire, which is 14 questions, so it's a little bit more.
Not
But
bad.
not bad. It was only needed to be administered initially during that perinatal period. PTSD, 4 questions. 4 questions. That's not even a minute of your time to administer. And it only needs to be done once. And then this is one that you'll see, which on the asterisk by it. This is one we personally at Mommy recommend is the health-related social needs screener. It is longer. It's 27 questions. And if it's not able to be administered in the clinical setting, then we recommend getting with a community-based organization that can administer this. Is because we know that a lack of or people with social determinants of health needs, right? Housing insecurity, food insecurity, all of these things, right? That only amplifies or exacerbates, their situation and likelihood that they will experience a mood disorder. So we recommend the 27 question. If you don't want to do it, we'll do it. Send them us.
The core is the 5 core questions focus on the main areas of exactly. So we're looking at housing and utilities, transportation, food, and safety. And
It's a present much.
so I talk about that in that same tool in some of my presentations because the CMS and the Joint Commission that accredits healthcare organization. So CMS, which is, Medicare, Medicaid, they are requiring hospitals, nonprofit hospitals out at yes, easier and screen. Yep, they are tracking what my community's hospital is doing. It's actually our academic medical center.
Of course you are. You're amazing.
That screener is all over the country. Yeah, so that's pretty amazing to think about. And then once they finish the testing period, to pull it all together and get those results, I can't wait to see what that.
I can't wait to see either. Let me know. Yeah, we are going to sing. Can we? Yes, indeed. So, as a practitioner, well, now that you know the recommendations, you know what it is, how it affects mothers and babies, and you want to do some
change. You want to make changes within your organizations and you want to, start implementing some screenings. Well, how can you do it? Nearly every EHR system, it, electronics nowadays and AI and all that good stuff, it literally takes the brain work out for you. And EHR systems have it now to where you can actually automate assessments, right? So you can actually put it in their appointment reminder information. You can put it in their pre-registration. It can be done before they even get to your office. But if you're old school like me, you want to wait till they come into your office, you could actually give it to them at check-in information. They have to sit in the lobby for a good little minute. So give them something to do, right? They can actually fill it out there. They could do it at registration or they could do it upon rooming. So after you've gotten them back in the room, it's still a few minutes before the doctor comes in.
Right.
Now, I would recommend, at check-in and registration, so that gives an opportunity to actually assess and score those tools. But if it is your preference to wait upon rooming, that's fine too. We just care that you are screening. And I guess I should back up. The first step in implementation should be setting the mood. Like, before that client ever walks through your doors, she has to make an appointment. So there is an opportunity for a first point of contact, whether that is with your front desk staff when they call, even through your text and automation. Like, you can actually set a welcome and inviting tone. And then when they get to your office, what does your office say? Do you have any posters on the board, on the walls? Do you have anything inviting them or, telling them that it's okay if you're having a hard time? We call them "You're Not Alone" posters because,
Right.
shameless plug for PSI, Postpartum Support International. I think they are the ones that kind of coined that "You're Not Alone" slogan for perinatal mood disorders. They offer free post-its for you. All you have to do is request them. So set the tone beforehand. And that is a part of knocking down the stigma. If she knows she is safe. While after that mother has completed the assessment, anybody can actually score those assessments because they're self-assessments done by the moms. They're real easy. They come with a scoring grid. So from your front desk staff, they can actually score it. They can upload those, and if they're in EHR, they might already score them for you. So all the doctor has to do is take a few seconds, look at that score before he or she goes into the room and talks to that mama, right? After that mom has given you or is completed that assessment, give her some reading materials on it. Equip her with the knowledge before the doctor even gets in, so that way she has an opportunity to create questions that she may have.
Exactly.
Right? So, give information to her. The other thing is, as an organization who wants to start screening, you almost need to simultaneously build a network of referrals. So when we first got started way back in 2017, I probably thought we were crazy, but we randomly visited physician offices and pediatrician offices. And we asked about screening, and it all kind of stemmed from my pediatrician's office. She would give me this Edinburgh, and I asked her, I was like, if I score high, what are you going to do with it? She all but said it goes in a file. So that's kind of how I felt was, oh, okay, so no one calls, no one does anything. So on the flip side of that, for the ones that were not screening, their number one complaint was, we don't want to be liable if a mother tests or screens positive, and I have nowhere to send her. Maybe 20 years ago, there were no resources around this in the state, but there are now. There are several organizations, like Mommy as one, that is a local statewide resource that can help in this situation. But there are more certified practitioners
in maternal mental health now. Still not a lot, but as opposed to 0, I'll take 5 or 6. We have some. There are some resources. So it's imperative that you do the work, find the resources, right? So on this next slide, if you don't want to find the resources, I've done the legwork to find some for you. Here is the National Suicide Hotline, the 988 number. Love it because it's with the times. It's talk or text. There's also HRSA has a line, and I love their phone number. It is 1833 TLC Mama.
Oh,
When they get TLC Mama. And the good thing about their line, it's also 24/7 talk or text. They provide resources. It's confidential, of course. It's all warm lines, usually are. But they have translators in over 60 languages.
oh, that.
Yeah.
And it's a real person. That is cool.
Then you have shameless plug for a resource right here in Mississippi. UMC got a grant a couple of years ago, and they have Champ for Moms. And it is a psychiatric one line or one line for physicians that can call in that may have questions about psychotropic meds in pregnancy or postpartum. So we don't expect OBs to know everything, especially around mental health. So there's a resource, a partner for you. If you have a mama that you do feel like needs to be medicated, right? You have a line that you can call and get professional consultation in real time. It is 24/7 as well. And lastly, you have us. We also have what we call a warn line. It is operated 24/7, talk or text, and it's operated by peer support specialists. So you actually get, and this is mainly for moms. So you in real time get another mom that has walked the walk, gone through it. So on the other side, and occasionally we do have our therapists and clinicians also operating this line. So there are resources. So if you're curious to know what treatment options look like for these disorders where you have what we call talk therapy, that's probably number 1. Half the battle or half of the pathway to healing is saying it.
It is. Because you know what? You can't say it if you can't wrap your head around it.
Right.
Verbalize, vocalize what it is.
Hey, so that's where we tell. If you can finally get it out, then you're halfway there. So the other thing is medications, right? And it's a shame that just, 2023, we got our first FDA approved drug ever for postpartum depression. As recent as 2023. I dare not try to pronounce the name.
Wow.
But there's
2 years we've had.
so 2 years we had it. But the issue with that is here in Mississippi, it's on a STLT program. Yeah. So it is considered one of the more elite drugs, more expensive drugs. So you have to, for weeks to months, be on a maybe lesser ineffective drug, right? So that's precious time waste. So then you have combination therapy where this mom or person may need a little bit of both and may need medication as in addition to talk therapy. Then you have lifestyle and integrative therapies. One of my favorites, but I do know from personal experience, if you are in a severe state of depression, telling me to get up and walk for 30 minutes outside is like moving a elephant. It's very hard, but we do know that exercise, vitamin D does improve mood. So if you can get active, we do suggest get active. There are supplements like omega-3 fatty acids have also been shown to reduce mild depressive symptoms. And then yoga. Yoga doesn't only prepare our physical body, right, for labor and delivery, but it also reduces stress, right, and anxiety and other disorders. So
You can get a buddy, I mean, so it is hard. The hardest part of any workout or walking, putting on your shoe, walking to the door and walking outside, right? But if you have a buddy,
Then accountability partner.
absolutely, and they are going to wait for you, and when and if you don't show up, they're going to come and go on your door because they care. And that's what makes all the difference in the world. And you got some peer support woven into your programs anyway.
Yeah, we do. And actually, we've had doulas that actually do that with their client. Our doulas will go and get their clients and get them up and moving because they'll understand how much it helps their mental clarity. So I agree with you 1000%. Having the right support person that won't allow you to sit and stay. I like that. I don't know of any that we have here of the next, which is specialized perinatal psychiatric care units, other than one that's in the Delta, and it is primarily focused on mothers that are experiencing substance use disorders. Really cool program though. As they detox, they allow them to bring their child, and even if they have another child, if their child is under 5, they can bring that child with them too, because they understand the importance of what that child needs in that bonding period, right? So if I had the money and one dish, if I could, that would probably be mine to create. But then, of course, my favorite is peer support services. Anybody has the ability to be sympathetic, but in our case, we know that empathy goes a long way. When you actually have somebody that has walked that journey and can directly relate to you, that is an unshakable experience. So even though it's not over a blissful topic, it's important having peer support. So okay, well, because maternal mental health outcomes, they don't exist in a vacuum, right? They're typically shaped by race, ethnicity, language, social economic status, historical trauma, for some people, and systemic inequities. Culturally responsive care is not just a practice, it is a public health imperative. It is a must as we go forward, as we're talking about changing the way that we provide care, that we look at it from a culturally responsive lens. So what exactly is culturally responsive care? Culturally responsive care is the deliberate practice of recognizing, respecting, and incorporating a patient's cultural, linguistic, spiritual, and social economic backgrounds into their health care. If you'll see on this slide, I have used the slogan Burger King, have it your way. If we stop and realize that we are all servants and that we are all here in a servitude manner, meaning that if a mother comes in, your job is to serve her or to provide her with service. Keyword service. So it requires more than awareness. It requires action. So some of the core elements include acknowledgement of systemic inequities, right? I don't trust anybody that does not acknowledge the fact that there is historical trauma there for Black, Indigenous, Brown people of color within the healthcare system, because we know it exists, from the Tuskegee experiment to the unsanctioned sterilizations of women of color. That is history. So the first thing is we have to acknowledge it, right? And then we want to center the patient's identity. Really, we bring in, it's okay to talk about race. It's okay to discuss ethnicity, language, beliefs, gender roles, family structure. That actually plays a part in our care. If I don't know your family structure, you may not know your family history. That can, especially when we're talking about mental health, because we know if you come from a background of family, if not yourself, but your family has mental illnesses in your background, that increases your chances. So we need to know these things and we need to center it around that. We need to build trust. Back to the stigmatism, right? First step, we got to reduce it and we got to validate lived experiences. I am proud to say that now from when we started, um, mm, lived experiences weren't so much included in
More of it talking about them because I think we were saying cultural competence, and that just kind of covers everything. But the bottom line is, I can't understand somebody else's experience if my experience has been so different. I need to recognize that I may not be the best provider for. I've been trained. You want to be fair. I want to be competent. Again, yeah, I lack because I am who I am.
And I'm glad you said that. It's okay to pass along a patient if better care is the ultimate goal or is a consult. Exactly. I love the way you complete my thoughts. And then I guess it goes to my last point is tailor care plans, right? So tailor those around. So health disparities demand cultural responsiveness. Black and Indigenous women are 2 to 3 times more likely to die from pregnancy-related causes than white women. I stated that earlier, right? Women of color are less likely to have their mental health concerns bleed, diagnosed, and treated appropriately. For other people of color, language barriers and immigration status may also be something that deters them from accessing care, but then choosing to access quality care. There is a fear and distrust there. Worsening of outcomes. Black mothers account for 42% of births in Mississippi. That's a lot. And we're disproportionately affected by mental health conditions because of what I just said, right? About not heard, easily grazed over, and then a lack of treatment options available to us. Meaning Medicaid doesn't cover it. We don't see people that look like us. Or even if it's not a racial thing, we don't find people that have our lived experiences. That's what I.
And that is a different concept, but you can come from a different racial community, but life experience was so similar that you communicate and connect.
Absolutely. Right? Yeah. I think it's just about the connection. Find it. It doesn't have to necessarily always be about the color of our skin and white. Right. So some of those structural barriers, called compound interest, are implicit biases within the medical setting, lack of providers from diverse backgrounds, inaccessible or unaffordable mental health services. And then there's lastly, as I mentioned before, the historical abuse, therefore the distress in the healthcare field. So strategies for culturally responsive mental health care. First thing you need to do is provider trainings. Check out biases, right? There are tools and assessments out there that you can take just to see where you are. Because like you said, we all have bias. We're human. We are imperfectly imperfect. It feels like a better words, but NSPHI, I'm gonna put a plug in here for them. They offer like this series, several other trainings for providers, for community workers, health workers, all of those things. Usually, I'm not for sure if there's a cost, but I know that there's usually continuing ed associated with it, and you guys have to always have continuing eds. So look at provider trainings, bias assessments, Then we can also talk about community involvement in program design. So as you're thinking through, hey, this has really moved me to action, I want to implement some changes within my organization, I strongly suggest that you include community leaders. Those are people on the ground, boots on the ground, as we say. They're also oftentimes people with lived experiences, and they actually offer a plethora of information that you don't always get from a textbook.
Well, you can't get that from a textbook. And there's a name for those groups. They're called patient advocacy groups.
Absolutely.
And they are popping up more and more because of the kind of information that they can give.
Yeah. And they're change makers. Right. That's exactly what they are. They are change makers. And we love them. And their voices need to be incorporated because why? They represent your clientele. They represent the people that you are actually servicing and serving. So their voices are important. We say be fluid in your design at Mommy. We listen to not only the community as far as our professional partners, but we listen to our mamas. And all of our programs that we designed has been something that has been brought up either on a survey, in person, or we're in a class doing something and they say, I wish y'all had. We really look at, is this an option to create more service directly from what is being requested of us? So be fluid in their approach. Language access and interpretation. This is important. Can't get your message across if you can't get your message across. So your materials need to be appropriate, not only in language, meaning multiple languages or whatever, but also in tone of your audience, right?
Presentation of the information, because the words you use maybe they're
Ideas, here's or so it's either steer where it be.
So if you're serving a population at high school graduation levels, 50%, graduating level, do you want to give them a pamphlet full of words, things to read? You may want to take an approach of more pictures. Pictures can also get messages across. So just, being nimble in your approach on how you're delivering information. Diversifying their workforce. That's important. Representation is always important. So recruit, retain biopic healthcare providers, start doer programs in communities. These are usually people within the community. So they already have the buy-in, trust, their things of that nature. Then also support pathways for underserved populations to enter healthcare professions. I don't know if it's still in place now, but I do know that the Delta, I forget who was sponsoring it, but I think they had a big grant where they were trying to recruit healthcare providers to the Delta because the need is so great in the Delta. And if they stayed something like 3 to 5 years, they wouldn't have
no debt.
Yeah. I don't think that's in place anymore. There are more programs like that are needed, And let's be honest, there's not a lot in certain areas. We are a rural state. So sometimes we have to dangle the cheese, to get what we need. So offering different pathways. And then lastly, honoring cultural traditions and support systems. So recognizing the role the spiritual leaders and elders, extended family members all play, and they're to integrate traditional and clinical approaches when appropriate. We are getting to the end. We're nearing this. I'm going to wrap it up here. So what are some actionable strategies to promote mental wellness? Well, knowledge alone isn't enough. Improving maternal mental health outcomes requires practical strategies. The healthcare providers, community leaders, doulas, midwives, institutions all can apply immediately. One, as we talked about, universal screenings and referrals. Imperative. We want to equip and empower the workforce. Knowledge is power. We want to integrate maternal mental health services into all care models as it relates to maternal health. We want to strengthen and empower the family unit, our partners. We want to equip them with the same education. The other thing is engage more with community-based resources. And then lastly, we are in the age of the digital era. So leverage those digital platforms, telehealth tools. One way that we are able to be statewide in our services is through telehealth services.
Right.
And the one good thing about COVID is that it actually forced us all to move at glacial speeds into the telehealth and digital era, but it also allows us to provide resources in areas that didn't have it too. So
Absolutely. Yeah.
So I would say key takeaways as I wrap this thing up is maternal illnesses are not just psychological concerns. They directly affect the infant's health, the infant's development, and ultimately the infant's survival. Early screening, integrated care models, and access to mental health services for pregnant and postpartum women are critical to improving outcomes. And with that, good people, I hope I have left you with something that is tugging at your heartstrings. If you are not screening, please start. If you're worried about resources, Mommy is here. And I will share with you over the next slide our contact information. And before we wrap up,
Thank you so much. Yes.
You're welcome. I have enjoyed my time with you.
Well, I have enjoyed sitting down with you in the room face to face. I know to hear more about your life experience and more about, the work that you're doing. Appreciate you are in an area of critical need, not only because you're here in Mississippi with the statistics that you shared, which are, but maternal mental health, well-being is an area of critical need. Absolutely. And as you well pointed out, it's all one body. So if one part of the body is hurting, the other parts are also going to be affected.
Yeah.
So, Lauren, thank you so much for sharing. Thank you.
thank you for having me and giving me the platform and the opportunity.
Yeah, absolutely.
Thank you.
So everyone who's joining us and who was part of this master class, we want to thank you for joining us today. Plan to join us for master class number 8. That class is delivered by Dr. Stephen Farrow, and he talks about mastering obesity and diabetes and says you can do it. And I know that you can. So we look forward to seeing you for that next master class. And at this time, class is dismissed.